First of all, I'd like to thank the committee for their overall interest in structural interventions and also for giving me the opportunity to discuss my thoughts on structural interventions and their potential for addressing HIV and STIs. When it comes to structural interventions in HIV, which is my field, the history of the idea traces back, I think, to two events. One, arguably, was an Institute of Medicine workshop that aimed to recognize the role of, quote, broader social forces such as economics, politics, and international affairs in attempting to slow or eliminate the HIV/AIDS epidemic. The report and the presentations it compiled never actually used the language of structural interventions. Instead, presented papers addressed the importance of basic social science theories for intervention purposes. The second event was an interdisciplinary meeting of researchers and policymakers that was organized by the CDC, and that was in 2000. The language of structural interventions did appear in that workshop, and the papers that it produced, as did the focus on barriers to and facilitators of HIV prevention. And this tension between these two approaches is reflected in my own work in thinking about structural interventions. So let me explain. In my undergraduate class, I have a section on structural interventions, and when I give the first lecture, I use the framing of the Titanic, a variation of which I've seen in other places as well, which essentially goes like this. If we were to analyze the health outcomes associated with the sinking of the Titanic in a traditional behavioral health framework, we might note that those who survived the disaster were in lifeboats and those who didn't were not. And we might conclude, therefore, that to reduce the number of deaths in future such accidents, we should make sure everyone knows about the life-saving capacities of lifeboats. We might even encourage all passengers to get lessons in how to get into lifeboats and even provide such lessons free of charge. But of course, we know that this would not have done much to increase the survival had another Titanic-like vessel faced a similar fate. In contrast to this emphasis on individual behavior, much of the structural interventions literature seeks to refocus our attention on the risk environment to understand how it constructs the choices available to individuals or the opportunities for individuals to make choices. It asks us to focus on the barriers to and facilitators of healthy choices. In the case of the Titanic example, such an approach might note that many passengers died because there were not enough lifeboats available to them. It wasn't then that they had made bad choices, but rather that they had bad choices to make. Focusing our interventions on such an analysis would result not in the development of educational materials or lifeboat entry skills, or at least not only such interventions, but instead perhaps in interventions like laws or policies that required enough lifeboats for all passengers. When I use this example in my class, my students are amused at this suggestion that we could solve the problem of drowning when the Titanic sank by providing information on the value and best ways to use lifeboats. But how different is that from informing people that they can prevent STIs and HIV by using condoms and perhaps having them build their skills to do so if they can't get condoms, or informing injection drug users that sharing syringes can transmit HIV but not making syringes available, or even worse, making it illegal for them to carry them. Impacting on the HIV and STI risk environment by expanding access to sex education, to condoms, to STI and HIV testing, to syringes, including by changing policies and ensuring they are enforced, has been an important strategy for reducing risk, to be sure, and yet these diseases persist. These strategies are not enough. Why? I would argue that it's because these solutions are implemented in a social context that is characterized by substantial social inequalities based on fundamental categories such as gender, class, race, sexuality that are deeply rooted and reproduced by social structures, systems, institutions. And this has critical implications for the likely success of any of these interventions, including their success in being implemented at all, as well as their success in reducing disease rates overall and inequities in disease rates in particular. Let's extend the Titanic example to illustrate. Suppose we used our risk environment framework and got laws passed to require that the Titanic too was equipped with enough lifeboats for all the passengers on board. If those lifeboats are accessible only from the main deck, there will likely be passengers who are never able to make it to the lifeboats because they are down there at the bottom of the ship. Moreover, if some people are down at the bottom of the ship because they are poor and or because their race or gender or sexuality and are relegated to the worst spaces at the bottom of the ship, either because they are expressly excluded from the better spaces because of these categories, or because they are effectively excluded because of the cost of the tickets, or because there are seemingly neutral rules that restrict their access based on those categories that are highly associated with their gender, class, or race, then requiring enough lifeboats for all passengers may result in fewer lives lost, but could result in greater inequities in the social distribution of those losses. When we do come to recognize that interventions to address health must be developed with an understanding of how social inequalities and the structures and institutions that undergird them shape health and vulnerability, this often leads to efforts to develop intervention approaches that try to minimize the impact of various social vulnerabilities. For example, in the Titanic example, perhaps we could employ some peer navigators or social service workers and locate them down at the bottom of the ship. Their job would be to help guide some of the passengers from the bottom to the top. Maybe they would even know some shortcuts or have keys to some of the doors that not everyone has keys for to make their success even more likely. Or perhaps we could develop interventions for these potential passengers that would empower them to advocate for themselves when booking their tickets to try to get better deals and better ship locations from the travel booking agents. These approaches are not unlike a lot of the interventions proposed to help facilitate vulnerable populations to better navigate the systems that are not necessarily responsive to their needs. For example, providing intensive case management services that may be available, but to help them better access services that may be available but disconnected and confusing to access, or empowering patients to ask their doctors for STI or HIV tests when their doctors won't offer to provide them. Such solutions aren't directly challenging the overall structure of the system and focus on changing it, perhaps because it seems impossible or too complicated or beyond the scope of a health intervention, but they are seeking to reduce the impacts of social vulnerability on health outcomes. Okay, I know the Titanic example is getting a bit tiresome at this point, but let me try just one other analogy. In spite of all the issues I've just raised, it is important to recognize that lifeboats are an effective tool for surviving a sinking ship. Just because there are these problems doesn't mean we should give up on them altogether. Similarly, we do have effective tools for preventing the acquisition of HIV and STIs, for example, condoms. But unlike lifeboats, perhaps, condoms are imbued with clear and complex social meanings. The use of condoms takes place in the context of a relationship, and these relationships are shaped by social understandings of, among other things, gender, race, class, and sexuality. Condom use is a social practice with a social meaning. For some, it may mean that you don't want to get pregnant, so if you're using some other form of birth control, a condom isn't necessary. But condoms are also associated with disease prevention, so condom use may suggest suspicion that a partner has a disease that she or he got from having sex with someone else that may or may not be acceptable given the understanding of the relationship. And in heterosexual sex, male condoms are generally under the control of men, and in a context of gender inequality or socioeconomic vulnerability, it can be dangerous for women to demand condom use. In minority communities, furthermore, condoms are sometimes viewed by some as tools promoted to limit the expansion of their communities. The point is, these are not neutral technologies because they are used in complex social contexts and cannot be separated from the social meanings they contain. Similarly, biomedical tools like regular testing, preventive drugs, and treatments are produced and used in social settings and cannot be disassociated from them. I would argue then that the most effective structural interventions for STI prevention are those that are based on an understanding of the meanings attributed to sexual behaviors and prevention tools and of the social world in which they are used, that recognize that fundamental social inequalities rooted in structures, systems, institutions that help produce them situate people in ways that make them more or less vulnerable to diseases, and that STIs and HIV may be particularly challenging because they're so fundamentally rooted in the most basic and arguably intimate of social behaviors. To recognize this complexity is not to suggest that we can't do anything unless we challenge the system as a whole. We can and have intervened in successful ways, but it doesn't mean that we need always to be aware of the different ways that this social world shapes the particular experiences of vulnerability. We need to consider whether some strategies are better suited to the needs of some forms of vulnerability than others, and make sure that we aren't focusing only on strategies that systematically benefit some, or even worse, actually, however inadvertently, may benefit some while increasing the invulnerability of others. So with all that said, and with not enough time to go into everything, let me just get a bit more concrete by discussing some of the work that I've been doing. How do we go about chipping away at intervening in the social world, structures, et cetera, of social inequality that produce these kinds of outcomes? I focus my efforts in two directions. One is community mobilization interventions, and particularly with female sex workers. Community mobilization approaches work to empower vulnerable communities in ways that make it more possible for them to confront the systems and relations that shape their vulnerability and thereby enhance their power to, among other things, engage in safe sexual practices. They support, in this case, sex workers in building their collective power to refuse to have sex with clients, to stand up to police who threaten them with arrest if they don't have sex with them or don't pay them some of their earnings, to determine for their collective community the appropriate price and conditions of sex, and to participate meaningfully in discussions with local, state, national, and international leaders about the legality and treatment of sex work and those who engage in it. Community mobilization approaches have taken different forms and have had different degrees of success, and there remains much to learn about this strategy, but two things are perhaps particularly noteworthy. First, they suggest that whatever intervention strategies we develop, we should be actively engaging in meaningful ways those who represent socially vulnerable communities in developing these interventions. The other noteworthy feature of community mobilization interventions with sex workers is that they're rarely used in the United States. Much more common in other countries, especially the Global South, which was where my work was done in southern India, though I do know that Susan's going to talk about some of her important work that's going on in the US in this regard. More recently, I focused my attention on mass incarceration and currently on the intersection of mass incarceration and housing. So let me just say a little bit about this. First, why mass incarceration? I'm persuaded by this growing literature that in contemporary US society, mass incarceration fundamentally reflects structures and reproduces intersecting social inequalities, especially gender, class, and race. As we probably all know, the US incarcerates more people and at a higher rate than any other country in the world, and that there are disproportionate rates of incarceration by race. Mass incarceration is not just about the individual experience of incarceration. The reach of the criminal justice system extends to community supervision, hyper-policing, hyper-surveillance, whereby entire communities are subject to the gaze of the criminal justice system, and criminalization, which is signified by the ways that individuals with a criminal justice history continue to be punished even after their sentence has been served. A growing body of literature is coming to characterize mass incarceration as a fundamental social determinant of health. Why housing? For one thing, we know that housing or lack thereof is associated with a wide range of health outcomes. There are even various initiatives, policy or programmatic, that seek to make housing a prescribable solution to various health conditions. In the HIV literature, provision of housing is one of the best examples of a structural intervention to treat HIV. Less attention has been paid to the benefits of housing in HIV prevention, although of course they're related. But in a recent paper led by some of my colleagues at Yale, we show a robust association between county-level eviction rates and the rates of chlamydia and gonorrhea, independent of other known predictors of STIs. Perhaps this should not be surprising. Housing is critical for maintaining stable relationships. When women have access to stable housing and can support themselves, they can end violent relationships potentially. And access to stable and affordable housing may reduce the need to engage in sex exchanges. So how does mass incarceration and housing intersect, and with what implications for STIs and HIV? Short answer is many and complex different ways, but just to sketch out one piece of this story, there's a serious shortage of affordable rental housing in the United States, but subsidized housing policy represents a primary mechanism for addressing this by increasing access to affordable rental housing among the poor. Even so, only about 1 in 4 eligible households receive HUD assistance. And if that isn't bad enough, access to these programs is restricted based on criminal justice history. Federal law requires anyone who's been previously evicted from public housing for a drug-related felony to be banned from public housing and related programs for a minimum of 3 years, and it permits eviction when the occupant or any visitor or guest is found using illegal substances. These rules provide minimums, but they also leave landlords and housing authorities with a good deal of discretion. For example, some may add years to the minimums. Others may stipulate rules about how they define evidence of a criminal justice history. While such discretion allows them to be generous in their interpretations, they may also be explicitly or implicitly making determinations about deservingness or lack thereof that further stigmatize some types of crimes or criminals. These rules also have a disproportionate impact on blacks, given their disproportionate representation in the criminal justice system. Indeed, these disproportionate impacts directly controvert the intentions of the Fair Housing Act. although the current administration is proposing to actually end or essentially end the legal tool of disparate impact under the Fair Housing Act. While we typically focus on the race impacts of these policies, it's also important to consider their gender implications. Given that men are disproportionately among those incarcerated, it is women who are more likely to be the providers of housing. It is important to consider what it means to be the one most likely to have access to housing in a community still characterized by gender inequality, with men circulating in and out of the criminal justice system. What vulnerabilities come along with the potential power of access to housing? In short, there's a complex interaction between mass incarceration, housing, and STI HIV risk. This means that there are many different potential intervention points at the policy level, at the level of social service, at the level of health services. But along with these strategies, we should also consider some even bigger picture ideas. How might we challenge the impulse to solve social problems with punitive criminal justice approaches? What difference would a different approach to corrections make? What would be the impact on health generally and STIs of a particular intervention aimed at keeping youth out of the criminal justice system and addressing their crimes with alternative strategies? Why should criminal justice history determine access to housing? And why is there so little housing access to begin with? We may not have the power to implement interventions to address all of these things, but our research can also provide an evidence base for those attempting to do so. Even as we focus our intervention efforts in domains that may be considered more typically in the realm of public health, those efforts will be stronger the more they recognize the social meanings and the social context in which they are being proposed and implemented. Thank you.